Hello, my name is Karen Hasty, and I am a professor of orthopedic surgery and biomedical engineering at the University of Tennessee Health Science Center and affiliated with the Tennessee-wide Institute of Regenerative Medicine. Today, I'm going to talk to you about our program of interventional and cellular therapies targeting osteoarthritis. Effective treatments are desperately needed for OA and PTOA. It's the most common musculoskeletal disorder worldwide. This disease has major economic consequences. There are no disease-modifying osteoarthritis drugs to date. In our research group, we're focusing on early diagnosis, arresting progression, and restoring normal function. And I'll be giving you an overview of a few of the approaches that we are taking. If you look at the development of arthritis as a progressive stairway, we'll see that some of these steps are longer here for the early stages, but they all progress to the later stages and to the bone-on-bone that mandates total joint replacement at this time. We think that there's a window of intervention much earlier than the late stages, which is a sweet spot for therapeutic intervention, and that we can accomplish repair and regeneration in a reasonable period of time with this aggressive early intervention. Now, in our animal model of compressive knee overload, which was originally developed and characterized by Poulet and her collaborators, we have seen that one of the earliest signs of this degenerative process is the loss of proteoglycans and saffron and O staining at the articular surface. Now, this correlates with the reports in other models of dog models and human models of degenerative OA. To quantitate this unmasking step, we have developed monoclonal antibody to type 2 collagen as a targeting agent for damaged cartilage and as a quantitative measure. Using this monoclonal antibody, we can show that it will localize in the joints of knees that have been damaged as compared to normal knees, and that control antibodies similarly used with fluorescent dyes do not localize. We can get a quantitative measurement of the fluorescence in the joint that can be used to evaluate therapeutic interventions. We can also use this in a fluorescent arthroscopy approach, that is, by creating surgically induced damage on a pig knee and then incubating the antibody in the joint cavity. We can see that it binds to the damaged cartilage, and we can do quantitative measurements of that fluorescence. So we can use both small and large animals. What else can we do with this antibody? Well, we can target theranostic liposomes. Theranostic liposomes have the ability to diagnose and to deliver therapeutic agents. And here's a little schematic of how this happens in the joint, with the nanosomes binding to the type 2 collagen and then undergoing burst lysis, releasing their cargo to the cells in the damaged cartilage. Here is an IVUS scanning of these theranostic liposomes injected into the knees of young and old guinea pigs. These are Duncan Hartley guinea pigs, which with age develop degenerative OA. Here we see the histopathology, and we can see that more fluorescence binds in these knees of these older guinea pigs. So we can get both delivery of a therapeutic agent and a readout of how much damage is present. So what shall we put inside of these theranostic nanosomes? Well, we decided to try to impact a major inflammatory pathway by inhibiting activation of NF-kappa B. We know this is a major transcriptional factor for pro-inflammatory gene inductions, and associated with the activation and induction of inflammatory genes like cytokines and chemokines and other genes involved in chronic inflammation. If we treat the PTOA mouse model with theragnostic nanosomes loaded with TPCA, we can see a decrease in MMP activity, shown here with the fluorescent substrate and IVUS imaging. So this knee does not have as much MMP activity as either the untreated knee or the knee treated with TPA solution. So we also see that the amount of exposure of the type 2 collagen epitope is shown by antibody to type 2 collagen is also decreased. So these are beneficial effects that we would like to see. If we look at these joints, the histopathology, we see that there are the joints that are treated with the TPCA-loaded nanosomes that are targeted show very good cartilage at this point. This is 6 weeks out from the start of the mechanical loading. And whereas the ones with empty nanosomes or TPA solution do not show as good as this histopathology. Treatment of these joints, we can remove the messenger RNA from these joints and measure genes of interest. We can show that MMP13 is decreased with the theranostic nanosomes, as well as IL-1 beta, but there is an increase in the expression of aggrecan. So this is encouraging. So now there's an increased expression of aggrecan. What about if we just target MMP13 in this array of inflammatory genes? What does that do? Working with Craig Duvall at Vanderbilt, our collaborator at Vanderbilt, we use targeted monoclonal antibody to type 2 collagen bound to siRNA multiplexes. We can show that the siRNA for MMP13, which would deposit onto the matrix and then be released in a longer-term manner, we can show that these are very beneficial. They localize to the gene, to the knee specifically. They reduce expression of the gene, MMP13, and they show good histopathology for the treated versus the untreated joints. And this is 6 weeks out. So this is very good progress in protecting the joint. Now, pharmacological approaches and siRNA approaches can prevent cartilage degradation in the early stages of disease. But where significant degradation has already occurred, we need to rebuild cartilage and recreate the bone cartilage interface. But in the earlier stages, we can use mesenchymal stem cell to provide additional benefits because of paracrine factors that may act on endogenous repair or regenerative response, as well as the inflammatory response in the synovial tissues. We have seen that in the mouse PTOA model, the injection of adipose-derived stem cells reduces serum NO, MMP13, and IL-1 beta expression, and increases expression of cartilage matrix genes, aggrecan, and type 2 collagen. Now, this is very encouraging. Unfortunately, these cells do not bind to the damaged or normal or articular cartilage. To encourage these cells to enhance their binding to the damaged cartilage, to provide increased amounts of these paracrine factors, we are labeling these adipose-derived stem cells with the monoclonal antibody to type 2 collagen. This is done through an avidin-biotin linkage, labeling both populations of antibodies and adipose-derived stem cells and injecting the mixture into the joint where the antibody binds to the damaged cartilage and recruits the biotinylated avidin labeled adipose-derived stem cells. We can show in vitro that this works. Here's our cartilage explants that have been scratched on the surface with a scalpel. We see that the monoclonal antibody targeted fluorescent stem cells binds to the articular surface, but an irrelevant monoclonal antibody on the surface of these cells do not. It's seen similarly if we damage the cartilage explants by trypsin. Here we see the monoclonal antibody to type 2 collagen provides more extensive binding of the stem cells to the cartilage surface. And we can measure that fluorescence to give us an estimate of how many stem cells are actually present. So we have turned this back to the pig knee to see if this will work in a larger joint. And yes, it will. Dr. Azar from Campbell Clinic, our collaborator from Campbell Clinic, did fluorescent arthroscopy to damage the knees of these domestic pigs. And then they were injected with 6 million porcine adipose-derived stem cells that were fluorescently labeled. The pigs were allowed to recover and were up and walking around for 4 days before they were euthanized to explore if there were cells that had bound to the articular cartilage surface. And we could see, yes, they were only in the areas that were damaged with the curette and into the soft tissues as well. But that's all right because we need to downregulate the activation of the synovial macrophages. So in conclusion, we've developed multi-pronged approaches to identifying and treating OA. These have proved effective in a mouse model of P2A. We can identify early lesions. We have a way of targeting soluble compounds or cells to these lesions. We can prevent progression with the compounds and siRNA targeted to the degenerated cartilage, showing a beneficial reduction in inflammatory cytokines and degradative enzymes like MMP13, collagenase, with an increase in the anabolic genes that are important to stimulate matrix resynthesis. And I'd like to recognize my collaborators from UT-HSC and Vanderbilt University. And this work was funded by funds from the VA as well as NIH. Thank you.
The title of this talk is Systemic Delivery of Mitochondria Improves Regeneration and Restoration of Function in Skeletal Muscle After Injury. Skeletal muscle has a very good potential for undergoing repair. However, insufficient or delayed regeneration after muscle injury can lead to long-term functional loss. This is an example of a skeletal muscle injury that occurred in a young mouse and examined after 5, 10, or 21 days. And you can see that by day 21 after the injury, the muscle is quite well repaired. There are some central nuclei indicating that that is regenerated muscle. However, muscle from an old animal or human or one with diabetes, obesity, diseases of various sorts do not have the same repair process. So initially, while the muscle looks like it's repairing about the same in the old and young muscle, if you follow it further along by 21 days, that muscle has not recovered to the same extent as in a young animal. So there's a problem with some repair that undergoes muscle regeneration. And so we asked the question, could we affect that rate of regeneration after an injury in an animal model? To study muscle repair, we have to consider satellite cells or muscle stem cells that were first described by Morrow in 1961. These nuclei sit between the basement membrane and the plasma lemma of a muscle fiber. Normally, they're quiescent and they reside in this pocket, but when they're activated, they undergo division, proliferation, with some of their daughter cells undergoing self-renewal and remaining back in the satellite cell position, or daughter cells can migrate internally into the damaged area, undergo differentiation and transcriptional regulation of that muscle repair process. Satellite cells are a very small percentage of the total nuclei, about 5%. And we do know from a number of studies that if these satellite cells are ablated, then muscle repair will not occur. Mitochondria also have a role in regulating the muscle stem cells. In quiescent, mitochondria primarily rely on beta oxidation of free fatty acids to provide energy for the quiescent cell. But after the signal for division, the muscle mitochondria switch to a glycolytic phenotype to generate ATP for the division. And then during the differentiation, oxidative phosphorylation, or OXPHOS, becomes a primary source of providing energy for the differentiating muscle fibers. There is an increase in reactive oxygen species that is generated from the OXPHOS process within mitochondria. However, mitochondria can become damaged. They can become damaged when the injury insult itself through disease, aging, high levels of oxidative stress, or high levels of cytokines. And damaged mitochondria mean poorer muscle repair. What we know is that if we add healthy donor mitochondria to cardiac muscle that has undergone ischemic reperfusion damage, those donor mitochondria do improve muscle repair. However, what we do not know is if we add healthy mitochondria to damaged skeletal muscle that is not damaged through ischemic reperfusion, whether we will also improve the recovery of muscle function. Our hypothesis was adding healthy mitochondria systemically through the process that we call mitochondria transplant therapy, or MTT, will improve skeletal muscle injury and repair or regeneration and recovery of muscle function in mice. We first wanted to know whether donor mitochondria would be taken up into muscle cells, and these are examples of muscle myoblasts in culture taking up the green fluorescent donor mitochondria that were added to the cell culture medium. You can see that the mitochondria are taken into the cells and also in differentiated myotubes, which are labeled by the red fluorescent myosin heavy chain. And you can see the green mitochondria are taken into those cells as well. The blue labeling are for other nuclei. You can also see that some of the mitochondria that are taken into muscle fibers become perinuclear. And in fully mature skeletal muscle that have added donor mitochondria to it, will take up those mitochondria as well. So it doesn't have to be just undifferentiated myoblasts, but adult muscle fibers will also take in the additional mitochondria. So knowing that the model works, that mitochondria are taken into muscle cells, we use barium chloride to injure the gastrocnemius muscle on one side of a mouse, whereas the contralateral side served as the intra-animal control uninjured muscle. 24 hours after the injury, we isolated mitochondria from our donor mice with green fluorescent mitochondria, and 50 micrograms of mitochondria were injected into the tail vein of injured mice. Alternatively, phosphate buffer saline of the same volume was injected into the tail vein of injured mice as the comparison group. 24 hours after the mitochondria injection, which is 2 days following the initial injury, we measured cytokines and collagen transcripts in the muscle. Then 7, 14, and 21 days, we removed the muscle to measure muscle wet weight, the force produced by the muscle, fiber cross-sectional area, and then looked at transcriptional regulation of various signals. These are raw force records of control fibers that were uninjured, control gastrocnemius muscles in the black for both PBS and for MTT treated animals, which are not different. What you see is the blue line, which is a PBS control muscle, is quite depressed, as is the green MTT line of the injured muscle. So roughly 46% of the force was lost 7 days after the injury had occurred. So repair had occurred, but we're still looking at a 46% loss. By day 14, there was a substantial increase in the MTT treated force production. And you can see that the difference now between force and the control side on the injured and controls are very small, about 3%. But that was not the same for the PBS muscle. Force had not recovered from the 7-day mark. And you can see that this is a significant difference between the MTT and the PBS treated animals. However, by day 21, there was an improvement in force production in the PBS muscle so that there's a lesser deficit as compared to the undamaged side, whereas the MTT treated animal was not different from the control level. There still was a significant depression of force in the PBS treated animal. So the muscle force recovery had not occurred by 21 days after injury in the PBS muscle, but it was fully recovered in the MTT treated muscle. Gastrocnemius wet weight decreased about 26% in both the blue PBS and the green MTT treated animals by 7 days after the injury. This had improved in the MTT treated animal so that it was not different from the uninjured animal after 14 days, but it was greater than the PBS muscle, which had not improved its cross-sectional areas or its muscle weight at this point in time. But by 21 days after injury, there were no differences among the groups. And you can see that the muscle mass had returned to control levels by that point in both animal experimental populations. Muscle fiber regeneration was also examined after 7, 14, and 21 days. We did not find any changes in the type 2A population, which are indicated by these green fluorescent stained fibers here. 2B fibers, which are the more copper-colored fibers, did show some significant changes. We found marked decreases in the overall average cross-sectional area for both PBS-treated and MTT-treated animals. No differences between the two groups after 7 days for the type 2B fibers. And you see similar graphs for the cumulative frequency distribution and the distribution for the type 2A fibers. And you see that they're quite similar in PBS in blue and the MTT in green, but very different from the larger fibers that we see in the control muscles. So damage was substantial. Repair had begun, but it had not got complete. By 14 days, there was a marked improvement in the cross-sectional area of the MTT treated animals. And you can see that with a shift to the right in this green curve as compared to the PBS animal, which had not improved its fiber cross-sectional area to the same extent. And you can see that as well in the cumulative frequency distribution, as after 14 days, this green line has become closer to the undamaged muscle, but has pulled away from the PBS muscle, suggesting that there's marked changes, marked improvements in the sizes of those muscle fibers after 14 days. By 21 days after injury, there really now is no significant difference in the overall mean cross-sectional area of the control or the two experimental groups. But what we do see is that there is still a population of small fibers in the PBS treated group as compared to the MTT treated group. So now the MTT treated animals have a fiber distribution that is very similar to the undamaged control. But again, there is a population of fibers that are typically less than about 1,750 square microns that are smaller in the PBS muscles. We also measured fibrosis gene expression within 2 days after injury. And what we found were trends for lower expression of genes that included TGF beta 1, collagen 3, and collagen 5, but none of those reached quite significant differences. We also looked at the transcript for metalloproteases, and we did find that there was a significant reduction in the MTT treated muscle 2 days after injury as compared to the PBS treated animals, but other metalloproteases were not different. And that resulted in a difference in deposition of collagen during the repair process. So by 7 days of injury, after injury, where repair has begun, you see significantly high levels of collagen and non-contractile tissue between the fibers in the PBS treated muscle. And there certainly is a lot of deposition in the MTT treated muscle relative to the undamaged control. But what you see is that there is less deposition of the collagen and non-contractile tissue in the MTT treated animal at that 7-day period. However, by day 14, there really is no difference now between the PBS or the MTT treated animal in terms of non-contractile tissue labeling. And this was quantified from Gomori's trichrome through serological point count approaches. The conclusions from this study were that MTT did improve the regeneration of muscle mass and restoration of maximal force capacity, which is considered the gold standard for recovery after an injury, between a window of 7 and 14 days after injury. The systemic delivery of mitochondria through MTT did not increase early muscle regeneration or activation and repair, although it did have the tendency to depress some of the cytokines that were measured. MTT did suppress early non-contractile gene signaling, and it did suppress the deposition of collagen, particularly after 7 days of injury. The rate and the type of type 2B fiber adaptations, but not type 2A fiber regeneration, appeared to benefit from MTT. The limitations of this study were that we used liver mitochondria as the donor source, and we do not know if other donor tissues would have yielded the same systemic responses to MTT. We used only one systemic application of MTT, and we do not know if additional doses would have changed either the rate of response or the apparent resistance of type 2A fibers to MTT. We also use barium chloride as the source of chemically induced injury, and additional studies are needed to determine if MTT provides a similar regenerative benefit to other types of injury that are not barium chloride focused. I want to acknowledge our collaborators on this project and also our funding source from the Department of Defense. Thank you.
Hello, I'm Dr. David Anderson. I'm the Associate Dean for Research and Graduate Studies in the College of Veterinary Medicine at the University of Tennessee in Knoxville. My lab research area is biomaterials and development of animal models for testing devices for translational medicine. I'm also representing Dr. Madhu Dar, who's a research professor and the director of our regenerative medicine and tissue regeneration laboratory here in the College of Veterinary Medicine. Our program got an interesting start. Dr. Dar got involved with some of our clinicians who are equine specialists, and equine athletes suffer many of the same injuries that people do, muscle, tendon, ligaments, bone. And as a result of these injuries, very oftentimes they're either career ending or life-limiting injuries. And so the clinicians are always looking for better ways of treating these injuries to improve the outcomes of these animals. And stem cell therapies were starting to get popular. And Dr. Dar is a cell biologist, and she got really interested in studying stem cells and applying those to the treatment of disease. And so there was a natural fit there for a veterinary animal model that was spontaneously occurring disease where they could harvest stem cells and then use them to try to treat those injuries. And so Dr. Dar established the stem cell research laboratory here in the veterinary college, which we refer to as the regenerative medicine program now because the scope of the work is broadened out considerably. But when we think of regenerative medicine, we think of the art and science of replacing or regenerating human or animal cells, tissues or organs, and for the purpose of restoring or establishing normal function following impairment for any reason. And so we try to take a tissue engineering approach to this research. And so that has different facets to the program. One of them is stem cell therapy. And our program right now is mainly revolves around allogenic stem cell therapy. And so in veterinary medicine, we've looked at autogenic and allogenic therapies and have found that the variability in autogenic cells, either because of the lack of stemness or because of patient factors that limit the effectiveness of those cells, are less reliable. And so we focused on developing allogenic therapies for stem cell transplantation into injuries. But we've also tried to develop more complex ways of dealing with these tissue injuries. And so we're working on cell delivery vehicles, bioactive scaffolds, biomimetic scaffolds, and a variety of different drug delivery devices that can be used to deliver growth factors, as well as antibiotics and other drugs. So the approach is a little bit of the benchtop to bedside. And so we do a variety of in vitro investigations, exploring the cytocompatibility and cytotoxicity of different elements, trying to refine the concentrations of bioactive factors that should be incorporated in some of these scaffolds. And then we translate those into animal models. And so, and we're talking about preclinical models. And so we model these things in vivo to try to determine if we can translate what we've developed in the lab into the clinical setting. And so one of the interesting things for veterinarians is that the animal models that we use are oftentimes the target species for the work that we want to do as clinicians. And then we have a variety of ex vivo ways of evaluating these therapies, which I'll touch briefly on. And so we try to have a comprehensive program. And so having the horse as an example, this is just a pictorial diagram of doing a sternal bone marrow aspirate. The sternum is one of the best sites in horses to get bone marrow. And then stem-like cells will be isolated from that bone marrow. They'll go through the trilineage differentiation process to prove that they're multipotent cells that can turn into bone, cartilage, or fat. And then they'll be fully characterized. And the Dr. Dar's lab has found that there are certain surface proteins that make cells extremely poor stem cell donors. And she's also identified animals that we would refer to as super donors. And so their cells are extremely active and the animals are very prolific in producing those cells. And so those become ideal donors to help treat other horses. And so, this process can be fairly intensive, but our lab personnel are very gifted at isolating these cells, characterizing them, and then propagating them. And one of the other nice things that we like about allogenic cell therapy is the fact that it's about as close to off-the-shelf treatment as we can achieve. And so the time period from disease diagnosis to cell therapy intervention is relatively short, just a few days. And there are a variety of lesions that our clinicians have used, including injuries of the hock and the fetlock and the stifle and the knee. So these correlate to different parts of the human body, but the horse is a pretty interesting animal, the way it's anatomically put together. And the clinical trials that are going on right now, Dr. Dar has an FDA permit to do allogenic stem cell therapy in horses, and they're acquiring cases to determine what morbidities are associated with allogeneic therapy, as well as what the outcomes are. And so trying to connect the science to the application and ensure that we're doing something beneficial for the patients. And so building on this work, we've tried to use a tissue engineering approach to try to combine these different sciences. And so bioengineering, biomaterials, biotherapy, putting those together to try to create ways of treating injured tissues and restoring patients to high quality of life with normal form and function. And so what we're doing right now is developing new scaffolds, combining those with cells and other bioactive substances, which might be growth factors, but oftentimes are nanoparticles. And I'll touch on that in a moment. The purpose of these scaffolds and cells is to try to regenerate tissues more efficiently, more precisely, and get the patients back to a fairly normal activity. So this process of harvesting the cells, embedding the cells in scaffolds, and planting those into tissues and whatnot is really fascinating. And the idea that we can treat lesions that in the past might not have been effectively treated, is what keeps us, striving ahead to try to get better. And so what our scaffolds primarily are built around right now are polymers. And so we're developing composite polymeric scaffolds. And originally that was multi-component mixes and sometimes layered manufacturing of these complex scaffolds. We're trying to build things that have three-dimensional structure, that have some strength and integrity so that they can stay intact, but also can absorb fluids, provide highly porous spaces for cells to grow into. And the goal ultimately is that these scaffolds would be degraded and eliminated from the body, and the patient would be left with their own tissues as opposed to a permanent implant. What we're pushing into now is 3D printing, and we've been 3D printing scaffolds with bioactive components for a while now. But recently we acquired a cell bioprinter, and so we're simultaneously printing scaffolds and cells together. So one of the nanoparticles that's pretty interesting are carbon-based. And so graphene particles have the ability to stimulate different types of tissue. And so we've done a fair amount of work with graphene and its ability to serve as an osteogenic platform where bone formation occurs. But we've also seen graphene be functionally useful as a neurogenic platform. And so we can grow nerve cells on graphene as well. And so, one of the things we're trying to figure out is, what's the best way to mix this? What's the dose effect? And certainly variations in where we put it in the body will determine some of its function. And so that sort of leads us into what we're doing with animal models. And when we look at animal models, we're trying to pick the best aspects, from those animal models so we can minimize confounding variables that might affect the outcome of the research. And so we look at physiology, we look at translational validity. Is this something that you might be able to apply in a clinical trial development? The size and the species and whatnot. There are a lot of different factors that we take into account. We generally start with small mammal models, mice and rats, move up to rabbits and pigs and goats and even sheep. We don't do very much with canine and equine research unless it's non-destructive, and we're not doing anything with primates right now. But we have the infrastructure and the experience to be able to work with this full gamut of animals, and we feel like when we've gone from a rat to a rabbit to a goat, that we've gotten extremely close to being able to implement human clinical trials if all of these things are evaluated positively. And so we use a lot of different orthotopic models. And so in the rat, the most common things that we do are the tibia and the femur and the skull. We also use the rat as our preferred model for proof of concept testing for peripheral nerve regeneration. And so we're building some 3D printed scaffolds with nanoparticles incorporated in them to try to encourage axonal elongation, but also to support the Schwann cells and other supportive cells that help in nerve regeneration. And so not all of our therapies include cells. We have cellular treatments and acellular treatments. So an acellular treatment would be a 3D scaffold with bioactive nanoparticles and probably loaded with some type of drug. Cellular treatments would be ones where we're not just loading the cells onto the scaffolds, but we're actually incubating them for a period of time to allow the cells time to attach. And we've shown that in these 3D scaffolds that when we load cells into them in culture, that not very many of those cells drop out of culture onto the culture plate. And so they do have a surface that the cells are attracted to and are able to establish themselves. We use a variety of in vivo assessments in our larger animal models, ranging from thermography and radiography to CT imaging and DEXA. We do a variety of pressure mat and force plate studies. We use fluorescent bone labels and serum biomarkers in our research. And so one of the things I like about some of these larger animal models is the ability to do digital radiography serially. And so, we can do this over time and do temporal associations with tissue regeneration, which is what's depicted in this lower right-hand corner. We have a DEXA scanner, and one of the attributes of the DEXA scanner is that when we have to use orthopedic implants to provide stability while we're studying a tissue regeneration scaffold, the single beam imaging that the DEXA does allows us to measure bone density serially in the live animal without having to move the implants. When we want to do that with a CT scan, we need to take the implants out in order to avoid the artifact. We do perform CTs, sometimes after harvest of the tissues, but also often during the healing processes of the tissues, as long as we don't have metallic implants in place. Our clinical CT that we currently has is limited in resolution to about 500 micrometers, and we would like to get a unit that can get us to a much lower resolution than that, or much higher resolution than that, but that's what we got at the moment. And this is the Texan pressure mat system that we use. One of the reasons that I like this over force plates is that it's easier to get consistent runs and be able to get measurements and measure stride lengths and things like that, impedance. And the force plates just are more problematic in trying to get consistent measurements. And so, we appreciate that. In ex vivo measurements, when we harvest these tissues and whatnot, we do a variety of things. And one of the things that we enjoy here is that we can do everything in fresh tissue except for histology. And so we'll harvest the bone, we'll do a mechanical test on it. We might do a CT examination on it or a DEXA scan, microbial culture. We do as many things as we can before we fix those tissues and do histology. And we do a wide range of histology here. We prefer to do H&E staining on decalcified bone just so that we can get the fine cellular details so we could really look at what's happening in the tissues throughout these scaffolds. But because much of our research is focused in bone, we also do undecalcified bone histology so that we can quantitate the amount of mineral deposition and osteoid and whatnot that's laid down in these tissues. And these stains here, the Moncasa and the Goldner stain, are showing bone regeneration within a polymeric scaffold in goats over a period of 1 year. The fluorescent labels are valuable. We use those in the past a lot more than we do now, but mostly what we are using the fluorescent labels for are to evaluate mineralization fronts and sometimes mineral apposition rate to see if we're having a positive impact on healing. In Dr. Dar's lab, they do a number of immunohistochemical stains. And one of the things is with the tissue type stains is we never felt like we had enough specificity for what we were looking at. And so the immunohistochemistry gives us a better idea of what specific cells are in the tissues and how they're interacting with the tissues. So if you take this as a comprehensive approach to research, particularly the opportunity to use the larger animal models, we feel like we can get a really comprehensive assessment of these technologies, and so that when we're carrying things forward into clinical trials, we feel like we can do that safely and effectively. And so, I'll put a plug in here for veterinary and research scientists as part of the collaborative team. We have an excellent knowledge in comparative anatomy and physiology, as well as the husbandry of the animals and the surgical skills for a wide variety of procedures. We have realistic expectations of animal models, and so we try to pick animal models to meet the need rather than to meet the budget. We try to apply ethical decision making when we're picking these animal models, and then hopefully we have the ability to mitigate health concerns during the research that might confound the results. So I need to acknowledge sources of funding. We're deeply grateful for the federal institutions, especially the Department of Defense, the National Institutes of Health, and the National Science Foundation. We're also deeply grateful for internal resources that we have to help sponsor our work, including the Center of Excellence for Livestock Diseases and Human Health, the University of Tennessee One Health Seed Grants, and the University of Tennessee Office for Research, Innovation, and Economic Development Seed Grants. And finally, I have to thank the people that make this happen. So our staff, our students, our faculty collaborators. This is a serious team science approach to research, and we're deeply appreciative of the time and expertise of the people we work with. So thank you very much for allowing me to talk a little bit about the work we're doing in East Tennessee, and we look forward to seeing you in a meeting sometime or potentially collaborating with your research. Have a good day.
I would like to thank for the organizer for this opportunity to allow us to showcase our work. And we are very excited to take part in the World Stem Cell Summit for the second time. My talk is about using a pharmacological intervention to heal dental cavities by activating dental pulp stem cells. Lysophosphatidic acid, a lipid mediator that has growth factor-like properties, is something I discovered in the late 80s as a postdoctoral fellow, and ever since my work has been concentrated on its biological actions and development of therapeutics based on its action. In my very unique universe, in a galaxy far, far away, the brightest star is, needless to say, LPA. Why? Because it does everything under the sun. It controls cell survival, controls the cell cycle, cellular differentiation in many pathways, the cytoskeleton, and through that, cell motility, and gene transcription. So from these highlights, you can imagine that this very simple drug-like phospholipid has attracted our interest for a long time. The actual interest in applying LP as a treatment in this paradigm of dental regeneration stems from an experiment in which we were looking for the various LPA receptor expression in differentiating dental pulp stem cells committed to the odontoblast lineage. There are 6 LPA receptor subtypes, and we were particularly interested in the LPR2 subtype, which you can see that physiologically, under these differentiation conditions, over 21 days, decreases in its expression. And we have developed a hypothesis that by using a pharmacological inhibitor that we have at hand, specific to the LPR2, we can probably reproduce this effect and study what is the role of LPR2 in odontoblast differentiation. So let me introduce to you some of the dental stem cell pools. There are stem cells in all around this, the tooth, in the dental follicle, in the apical papilla, in the periodontal ligament, in the dental pulp, that is the most interesting to us. And what is unique about these odontoblasts that make up the bony part dentin of our teeth is that they are actually terminally differentiated cells like neurons or cardiac myocytes. So once we lose them due to cavity, they will not regrow. Differentiation from human dental pulp stem cells with a cocktail of growth factors and very complex medium formulation can actually mimic in vitro. But what we found is that our compound, PNUT01, actually accelerates this differentiation that is not seen in the control cells. As you can see, these cells resemble these elongated pointed cells that are odontoblasts. To give you perhaps more compelling evidence for the unique role of LPAR2 in odontoblast differentiation from dental pulp stem cells is through this silencing experiment of the LPAR1, 2, and the 3 receptor subtypes that are the major LPA receptors in these cells. And what you can see that silencing of the LPAR2 is the only one that after 7-day treatment with the silencing RNA actually causes calcification, calcium accumulation in these cultures, and that can be very well measured by alizarin red staining in these cultures. To drive this point even farther, this osteogenic differentiation of human dental pulp stem cells in this complex medium takes about 21 days. And as you can see at 21 days, this alizarin red staining clearly shows that there is a uniform calcification of the cells. What we find is that if we add PNUT compound into the basal medium, no other growth factor, just PNUT01, we can actually reproduce this calcification, calcium accumulation in the cells, but we can actually achieve this in only 7 days, 1/3 of the time that the polypeptide growth factor cocktail can accomplish in this well-established osteogenic differentiation medium. So that gave us a lot of excitement, and we tested this original paradigm that led to our hypothesis, and we measured the LPAR2 expression in osteogenic differentiation medium, as I have shown it to you in a previous slide, and also in the PNUT-treated cultures. And as you can see, the PNUT-treated culture also shows a substantial downregulation, not only just the functional inhibition, but the downregulation of the receptor subtype itself. And that is achieved at the same level as it is achieved in the osteogenic medium, but only in 7 days compared to 21 days in the osteogenic differentiation medium. So this shows a highly accelerated differentiation process hallmarked by the downregulation of LPAR2. To gather some additional evidence for the osteogenic dentin differentiation in these cultures, we have treated them with PNUT1 and measured various markers, bone morphogenic protein 2, RONX2, important transcription factor marker for osteogenic differentiation, and several others. I think that you can appreciate from the red labeled bars that already as early as 3 days, there is a significant upregulation of these morphogenic bone markers uniformly, and that is maintained and in some cases are enhanced as after 7 days of culture. So this certainly underlines the fact that these cells differentiate into the odontoblast lineage. Our mouse dentist, Jae-Young Kim, has wonderful hands, and he is not just a human dentist, but he's a mouse dentist. So in this experiment, in an effort to transfer our in vitro observation, he drilled a hole in a mouse molar, removed the enamel, and then drilled the hole all the way down to the pulp. That little brown spot is the pulp exposed. And then he loaded our compound at 5 micromolar concentration in a gel plug, and then sealed it with a composite. The readout that he applied is micro CT 6 weeks after this intervention. The top two panels shows AP and lateral view of the micro CT of these treated teeth. And what you notice in this case on the upper two panels is that the cavity is still open, and there's no closure of the gray appearing dentin layer. It's all the way through, so there is no regeneration of dentin as one would expect. But if you compare that to the PNUT treated cavity, you see that there's a contiguous dentin layer that has developed in 6 weeks, healing the bony deficit in dentin of the teeth. So this certainly extends our in vitro experiments and findings, in that we find a similar observation and regeneration of dentin in vivo. We took this one step further because our in vitro experiments were conducted with human dental pulp stem cells. And we have obtained some extra teeth from individuals. Some of us have extra teeth that usually are extracted and discarded, and we use them for a organ culture in putting these explants into a matrigel matrix, and either treating them with the control medium or compound P. And what you see that after 3 weeks, the accumulation of calcium, again revealed by alizarin red staining, shows a much more intense staining on the right here. And if you centrifuge the pellets of the calcium, you see that there is a substantially increased amount present in the compound pre-treated human explant cultures. So with this, we have obtained additional evidence that the phenomenon that we have observed in vitro not only is transferable to urine studies, but also to a human explant culture, organotypic culture. One additional potential use of this drug candidate is in the field of dental implants. As many of you know, once you need to have a dental implant, it takes about 7 to 11 months to actually fill in the cavity, post-extraction cavity, with solid bone that would hold the dental implant. So to model this situation, we we extracted a tooth and then treated it with just a medium and stained it for RUNX2, which is a bone morphogenic transcription factor and marker of bone formation. And we also treated controls with the PNUT compound. And as you see that as early as 1 week, you see many more of these RUNX2 positive cells indicative of profound odontoblastic, or actually in this case, osteoblast differentiation. And after 3 weeks, there is a solid bone structure that has developed compared to the control much more extensively. So this new bone now can actually hold an implant. So this study again extends our earlier observations that PNUT can actually enhance and accelerate the not just the dentin odontoblast differentiation, but also the osteoblast bone differentiation and formation in the alveolar bone of the skull. So our summary is that the LPR2 inhibitor promotes the differentiation of dental pulp stem cells into odontoblasts. LPR2 inhibitor PNUT regenerates dental pulp dentin in animal caries models. LPR2 inhibitor augments bone formation in the post-extraction cavity. And we are very excited about our future studies trying to develop dentin pulp regeneration products. With this, I'd like to acknowledge our collaboration, which is transcontinental, because half of our group is actually in Korea. In addition to my group, you see Il-ho Jung and Injun So, who are at the Busan National University, and Jae-young Kim, who is our animal dentist. His real job is a dentist, and he has been really instrumental in getting these studies done. With this, I would like to thank you for your attention.